study, we report updated estimates of prevalence, death, and disability-adjusted life years for chronic kidney disease, or CKD, from the Global Burden of Disease Study 2023. Spanning 1990 to 2023, our analysis provides an update to previous publications on GBD-CKD estimates and offers additional insights into this disease with reporting of prevalence by stage for the first time, as well as risk factor estimates. Our findings confirm that CKD continues to be a major global health issue, with rising prevalence and increasing importance as a cause of death and as a risk factor for cardiovascular mortality. Our study also confirms well-established knowledge that diabetes and hypertension are leading risk factors of CKD, but also offers more insights into the multifactorial nature of CKD drivers and outcomes. Over the past 3 decades, the number of adults living with chronic kidney disease has more than doubled, for a total of 788 million people in 2023. Although this is largely driven by global population growth and aging, the age-standardized prevalence has also moderately increased to 14.2% in 2023. We found that the majority of people with CKD had early stages of the disease, also known as stage 1 to 3 CKD. This figure is showing the number of CKD disability-adjusted life years attributable to various risk factors over age globally in 2023. We can see that the top risk factors for CKD are high fasting plasma glucose, high body mass index, and high systolic blood pressure, regardless of age. The number of CKD DALYs attributable to a risk factor rose over age until peaking in the 60 to 69-year age group. CKD mortality has also increased since 1990, and in 2023, CKD was the 9th ranked cause of death among adults globally. Of the other top 10 causes of death, only diabetes and Alzheimer's disease mortality rates also rose in the past few decades. Furthermore, kidney dysfunction as a risk factor was attributable for 11.5% of cardiovascular deaths, with this proportion rising steadily over age. Finally, high fasting plasma glucose, high body mass index, and high systolic blood pressure were all leading risk factors for CKD. In addition to CKD being a top cause of death directly, kidney dysfunction is also a top risk factor for cardiovascular mortality, with 11.5% of cardiovascular deaths attributable to kidney dysfunction, like I mentioned. Globally, kidney dysfunction ranked 7th as a risk factor for deaths due to cardiovascular disease, above other key risks such as high fasting plasma glucose and high body mass index. Fortunately, there are several effective treatments, including ACE inhibitors and GLP-1 receptor antagonists, that can slow kidney disease progression and reduce the consequent risk of cardiovascular disease, although these treatments are often underprescribed in high-income countries and likely even more unavailable globally. We found that the regions with the highest age-standardized CKD mortality and prevalence rates were also areas with high diabetes burden, such as North Africa and the Middle East and Oceania. Our findings also revealed a high burden of CKD in Central America, which may be related to CKD of unknown etiology, which is a more rapidly progressive and deadly form of reduced kidney function, seemingly unrelated to well-established CKD etiologies such as diabetes. We also found that treatment access to dialysis and transplant for people with kidney failure varied greatly by geography and income, with extremely low relative prevalence of people receiving kidney replacement therapy in sub-Saharan Africa. Furthermore, we found that CKD mortality varied across socio-demographic index, or SDI quintiles, with the highest rate in the lowest quintile locations, and then the lowest mortality in the highest SDI quintile locations. This figure is showing chronic kidney disease prevalence by stage and superregion in 2023 over age. The earliest forms of CKD are stages 1 to 2 and 3. The majority of people with CKD have one of these early stages, with prevalence steadily rising over age. Stage 4 and 5 prevalence also increases over age, with the strongest age pattern seen for stage 4. Prevalence of kidney replacement therapy, including dialysis and transplant, have much lower prevalence than stages 1 through 5. Dialysis prevalence increases in age until about 70 to 80 years, and there are key geographical differences for both dialysis and transplant. The high-income superregion in light blue had the highest prevalence rates of patients receiving dialysis and transplant, despite having stages 1 through 5 prevalence generally lower than the global estimate. Our findings support the WHO's decision to advance kidney disease as a non-communicable disease of increasing priority, along with other major causes of death and disability, such as cancer, cardiovascular disease, and diabetes. We hope that our data will be used to help advocate for more uniform implementation of well-established interventions that help prevent cardiovascular events and slow kidney disease progression among those living with CKD. Widespread testing of albuminuria in people at risk of CKD is also critical to detect this asymptomatic condition that is strongly associated with adverse kidney and cardiovascular outcomes, although uptake in policy has been limited even in high-income regions. Ultimately, we hope that our study can help inform strategies to recognize and diagnose CKD more efficiently and integrate CKD into general medical care.